Good morning, everyone. I, Logan Fonseca, along with my teammates, will be presenting information about trigeminal neuralgia. So what is neuralgia? Neuralgia is a type of neuropathic pain arising from damage or disease of somatosensory nerve fibers. Its effects range from mild to severe, and its subclassifications are based on location. Trigeminal neuralgia is a syndrome that is characterized by sudden, sharp, peripheral somatosensory pain that is along the course of the trigeminal nerve in one or more of its branches. It is also known as Trigeminal. Now let us understand the area supplied by the trigeminal nerve. The ophthalmic division of the trigeminal nerve supplies the upper part of the face. The ophthalmic division further divides into the lacrimal, frontal, and nasociliary branches. The lacrimal nerve, as the name suggests, supplies the lacrimal gland and some parts of the palpebra. The frontal nerve divides into the supraorbital and the supratrochlear nerve. The supraorbital nerve passes through the supraorbital foramen, turns upwards to supply the scalp. Similarly, the supratrochlear nerve also passes above the trochlea and turns superiorly to supply the scalp. From the nasociliary nerves arise the short and long nasociliary branches that innervate the ciliary body. Also, the posterior and anterior ethmoidal nerves arise from this and are present inside the ethmoidal air sinuses. The anterior ethmoidal nerve also supplies the tip of the nose and the medial and lateral walls of the nasal cavity. We move on to the maxillary nerve. The course of the maxillary nerve can be divided on the basis of its path inside the fosses. In the cranial fossa, it gives a small recurrent branch to the meninges that is known as the meningeal branch. In the pterygopalatine fossa, it gives off the zygomatic branch and it gives off the posterior superior alveolar nerve. The zygomatic nerve further branches into the zygomatico-temporal and the zygomatico-facial nerve. The zygomatico-temporal supplies the temples and zygomatico-facial supplies the cheek. The posterior superior alveolar nerve is a dental branch. The maxillary nerve continues as the infraorbital nerve in the infraorbital fossa. There it branches to supply the palpebra, the nose, and the upper lip. And it also gives some branches to the jaw. The ophthalmic and the maxillary nerves are purely sensory. However, that is not the case for the mandibular nerve. The mandibular nerve is both sensory and motor. The two nerves arising from the main trunk of the mandibular nerve are the nervus spinosus, which passes through the foramen spinosum to collect sensory information from the meninges, and the nerve to the medial pterygoid, which deeply innervates the muscle. The anterior division of the mandibular nerve is primarily motor. It gives off branches to the temporalis, the lateral pterygoid, and the masseter. The buccal nerve arising from the anterior division is sensory. It supplies the buccal cavity. The posterior division is mainly sensory. However, the nerve to the mylohyoid and digastric is motor, which is an exception. Now let's move on to the causes of this. The primary reason of trigeminal neuralgia is the close proximity of the trigeminal nerve to the superior cerebellar artery. This may cause some mechanical friction and may lead to demyelination of the nerve. Also, vascular compressions are seen to play an important role in this. There are some secondary factors that primarily affect other systems, but may extend to the trigeminal nerve. They may be systemic, structural, or related to some dental factors. In systemic, we have multiple sclerosis. Multiple sclerosis is a demyelinating autoimmune disease, which primarily affects the CNS. In some cases, it may demyelinate the trigeminal nerve and lead to misfirings and increased facial pain. The herpes simplex virus can affect and infect the trigeminal ganglia, causing localized pain and a swelling that can compress the ganglia. Intracranial tumors too can press on this nerve, damaging it. They may also cause vascular obstructions that may in turn lead to aneurysms of the vessels or an ischemic condition to the nerve. Ratner's jawbone cavities, or NICO, is a diagnosis in which cavitation of the jawbone can progress to trigeminal neuralgia. In this, the main nerve that is affected is the inferior alveolar nerve. If not treated properly, this has a very poor prognosis and causes the worst type of facial pain. And lastly, loss of teeth can trigger nerve degeneration, which in turn, under special circumstances, can progress to neuralgia. The remaining will be presented by my teammates.
Good morning everyone, this is Katyayani and I will be talking about the clinical presentation and characteristics of trigeminal neuralgia. When the patient comes to the trauma room or the clinic, the chief complaints will be sudden severe facial pain on one side, which is unilateral, which may be present for varying amounts of times, like for a few months or years. The pain is electric shock-like, and it may last a few seconds. This pain comes in episodes. It's not everlasting pain. It comes in episodes. It's triggered by mild stimulus like touching the face or chewing, talking, brushing the teeth, etc. There is pain-free intervals between these episodes. During history taking, we will come across the history of present illness. The pain will be unilateral, most commonly on the right side. The onset is sudden, paroxysmal, stabbing and electric shock-like pain. Duration of each attack may be from a few seconds to 1 to 2 minutes. Frequency is several times a day to multiple episodes an hour. Trigger zones are usually face and can be triggered by touching and shaving, brushing teeth, anything to do with the associated regions where the trigeminal nerve is supplying. It most commonly involves the maxillary branch, which is the second branch, mandibular branch, but it less commonly involves the ophthalmic branch. It's important to note that in classical trigeminal neuralgia, there is no radiation beyond the trigeminal distribution, meaning it's only affecting the trigeminal nerve and not affecting any other nerves or the region supplied by them. Between the attacks or episodes, patient is usually asymptomatic in classical TN, but in atypical TN, which is also called as secondary trigeminal neuralgia, a dull aching pain may be present. Patient is most commonly a female over 50 years of age. Past history, patient may present with a history of similar episodes, of course. It may have to do something with multiple sclerosis, as Logan said. Multiple sclerosis causes demyelination of nerves, which may be, and it's again important to note that multiple sclerosis associated with trigeminal neuralgia is especially important in young individuals, as multiple sclerosis presents early. A patient also may have history of facial trauma, dental procedures, history of tumors or neurological disorders. Treatment history. Since this is associated with the face and the area supplied is usually associated with other diseases or disorders such as dental pain, the mandibular branches, maxillary branches may be confused with dental pain or sinusitis, migraines, of course, the ophthalmic branches. History of anticonvulsant therapy. These are the drugs which are used as anti-seizure drugs, and they are given for diseases like epilepsy, neuropathic pain, bipolar disorders, and migraines, which might be the wrong diagnosis which was done before. And there may have been any surgical interventions if done previously. Family history is very rare during trigeminal neuralgia. It's hardly. Familial cases are very rare, but if it's secondary TN, then family history may be important during multiple sclerosis. Personal history, usually the patient is normal except for during the episodes. So appetite is normal, but sleep is disturbed due to pain. Bowel and bladder habits, it's all normal. But the important thing is the physiological impact. There may be anxiety and depression due to recurrent pain. And due to this recurrent pain, a patient may be highly afraid of eating or brushing, which are the stimulus which cause the episodes. During general examination, everything is normal except for the fact that patient is anxious and fearful of triggering the pain, which is eating or touching their face, brushing their teeth, which comes under psychological. Their nutritional status may be compromised if the pain is severe. As I said, if the pain is severe enough, they will avoid eating or brushing teeth at all, which will compromise their nutritional status. In systemic examinations, the central nervous system is normal, higher mental functions are normal, only the trigeminal nerve is affected and pain is triggered in its specific divisions. There is no sensory loss in classical TN, but if the sensory deficit is present, we have to suspect secondary TN, which is caused by other reasons. Motor function is normal, other systems are normal. Pathophysiology is mainly vascular compression, as Logan said, demyelination, which is multiple sclerosis, ectopic impulse generation, hyperexcitability, or abnormal brain transmission. Thank you.
Good morning everyone, my name is Neuralgia and roll number 46. Today is my topic, diagnosis of trigeminal neuralgia. Let's start with diagnosis criteria. If patient feel like recurrent unilateral facial pain and pain like electric shock and stinging style and triggered by innocuous stimuli, because trigeminal nerve is become hyper excitability. So normal touch signal as interpreted as pain and pain like limited to trigeminal nerve, आगे उससे नहीं बढ़ता है. देखो तो डायग्नोसिस ऑफ ट्राइजेमिनल न्यूरल्जिया. अब हर बार तो ये नहीं है कि वही ट्राइजेमिनल न्यूरल्जिया होगा, कुछ अलग प्रॉब्लम भी तो हो सकती है. फेस का मतलब दर्द हो रहा है तो कुछ अलग प्रॉब्लम भी हो सकती है ना. तो जैसे कि पेशेंट अब फेशियल पेन करने के लिए आया तो उसके बाद सबसे पहले तो हम उसकी हिस्ट्री लेंगे. और हिस्ट्री में क्या, जैसे कि पेन कैरेक्टर, जैसे कि बार बार सडनली उसको दर्द हो रहा है या फिर वो दर्द कुछ समय के लिए होता है, मतलब सडन यूनिलैटरल सेकेंड एंड शॉक लाइक इलेक्ट्रिक शॉक लाइक होता है. तो व्हाट कैन हैपन इफ इन जो ये मतलब कैरेक्टर अभी सिम्टम नहीं दिख रहे उसको, तो क्या प्रॉब्लम और हो सकती है. जैसे डेंटल पेन हो सकता है, साइनोसाइटिस हो सकता है, और टेम्पोरल मैंडिबुलर जॉइंट में डिसऑर्डर हो सकता है, माइग्रेन या हेडेक वाला भी हो सकता है. यदि ये हमको जो सिम्टम है वो दिख गए तो हमको ये सस्पेक्ट हो गया कि नहीं ट्राइजेमिनल न्यूरल्जिया ही है. तो इसके लिए ट्रिगर जोन आपने भी देखे थे। ट्रिगर जोन मतलब जो मतलब टॉकिंग या स्विमिंग एंड टचिंग फेस या फिर ये ब्रशिंग होती है, तो कुछ भी मतलब ऐसा मतलब फेस को टच करने पे भी हमको पेन फील हो रहा है, तो वो ट्राइजेमिनल न्यूरोलॉजी में आ रहा है। और फिर न्यूरोलॉजिकल एग्जामिनेशन नॉर्मल है, क्योंकि इसको ऐसे मतलब रिलेट नहीं कर पाएंगे उससे नॉर्मल सेंसरी और मोटर। अब यदि रेडियोग्राफी करे फिर एमआरआई ब्रेन या फिर ट्राइजेमिनल नर्व प्रोटोकॉल देंगे, तो यदि नॉर्मल है, नॉर्मल मतलब कि वो उसको नॉर्मल है केस में, तो आइडियोपैथिक या फिर क्लासिक वाला ट्राइजेमिनल न्यूरोलॉजी। यदि एबनॉर्मल में आ गया तो वो एबनॉर्मल में अपने सेकेंडरी फॉर्म हो गया उसका। एंड देन अब जैसे कि पता कैसे लगाए कि है ये ट्राइजेमिनल न्यूराइड है, तो उसके लिए एक ड्रग्स देते हैं कार्बाइड, एंड इससे पेन रिलीफ हो गया, तो हमको ये हो गया, कंफर्म हो गया कि वो ट्राइजेमिनल न्यूरोलॉजी है। बट यदि वो रिलीफ नहीं हो रहा है तो फिर रिकन्सिडर प्रोसेस। देन कैरेक्टर्स देख लिए ट्राइगर। देखो इस पर यदि सवाल आ गया ट्राइजेमिनल न्यूरोलॉजी पे, तो काफ़ी सिंपल रहता है, क्यों? क्योंकि इसमें सारा कुछ जैसे मतलब देखते बिना देखे पता लग जाएगा कि ये सवाल ट्राइजेमिनल न्यूरोलॉजी। तो मैं एक सवाल बता दूँ वही वाला। 45-year-old मैन है, उसको लेफ्ट साइड पेन है 3 मंथ से, एंड देन स्टबलिंग शॉकिंग लाइक फ्यू सेकेंड, मैन पेन इज ट्रिगर्ड एंड सी विल टॉक प्रोसेस हिज फेस अवॉइड ईटिंग साइड यू पेन ऑन एग्जामिनेशन देयर इज नो फेशियल मतलब एमआरआई ब्रेन शो डिमाइलेटिंग फ्लक्सेस इन द बोन्स। क्वेश्चन जैसे कि व्हाट इज द मोस्ट लाइकली डायग्नोसिस? ट्राइजेमिनल न्यूरोलॉजी है। व्हिच क्रेनियल नर्व इज इन्वॉल्वड? ट्राइजेमिनल नर्व। व्हिच डिवीजन ऑफ द नर्व इज अफेक्टेड इन द पेशेंट? व्हिच नर्व? तो देखो ट्राइजेमिनल नर्व की 3 ब्रांचेज है, ऑप्थेल्मिक, मैक्सिलरी और मैंडिबल। तो ऑप्थेल्मिक इतना ज़्यादा इन्वॉल्व नहीं है, बट मैक्सिलरी और मैंडिबल ज़्यादा इन्वॉल्व है, तो उसमें हो जाएगा। और इमेजिंग, देखो इमेजिंग स्टडी आर इम्पोर्टेंट बिकॉज डिस्टिंग्विश बिटवीन आइडियोपैथिक एंड सेकेंडरी फॉर्म ऑफ ट्राइजेमिनल न्यूरोलॉजी। क्योंकि ये एकदम दोनों सिमिलर है, इसमें हम इनको डिस्टिंग्विश करना जरूरी है, क्योंकि दोनों अलग अलग है। हम हर बार उनको ये नहीं बोलेंगे नहीं ट्राइजेमिनल न्यूरोलॉजी ये है। और इसके अलावा भी कुछ है, जैसे सीटी स्कैन हो गया, एमआरआई हो गई, एमआरए मैग्नेटिक रेजोनेंस एंजियोग्राफी हो गई, न्यू टेक्निक तो इनलार्ज व्यू हो गए, कन्वेंशनल एंजियोग्राम यूजफुल वेस्कुलर माल फॉर्मेशन हो गया। तो बस ये है, एक्स्ट्रा कुछ है। देखो ये मैंने एक सलमान खान का फोटो लगाया था, तो इस बीमारी से मतलब जूझ रहे हैं ये सलमान खान। तो इनको ऐसा फील होता है कि 1000 ऑफ नीडल प्रिक ऑन द फेस ऐसा। तो ये एमआरआई का था, मतलब क्या होता है कि ये क्रैम्प जैसा ही है। अब क्रैम्प हाथों में भी आते हैं, पैरों में भी आते हैं, वो नॉर्मल होते हैं, लेकिन जब फेस पे आए तो अलग बात है ना। तो क्या होता है कि ये ये अपनी ट्राइजेमिनल नर्व का रूट है, ठीक है, उसके ऊपर ये सेरिब्रल आर्टरी, सुपीरियर सेरिब्रल आर्टरी जनरली ये होती है। तो अब उसमें ये जो है डीप, जब इसको ये बंद नीचे मतलब कंप्रेस हो जाती है, तो कंप्रेस सिग्नल जा नहीं पाएगी, तो उसके कारण जो है वो वेस्कुलर कंप्रेशन होता है ना, उसके कारण जो है आपको पेन फील होता है। यही था। उसके बाद नेक्स्ट
Good morning everyone, my name is Shubhra Khade, roll number 49. So, as we all know, trigeminal neuralgia is a severe condition in which a patient's quality life is affected, and the main cause is vascular compression at the root entry. The main cause is the vascular compression at the root entry of the trigeminal nerve near the pons. And this causes the hyperactivity of the pain fibers, resulting in severe facial pain. So how do we treat it? The first line treatment, which is the medical therapy, in which we approach pharmacological therapy. The basic choice of drug is carbamazepine. Carbamazepine acts by blocking the voltage-gated sodium channels and stabilizing the hyperactivity of the pain fibers and stopping the pain transmission. There are also other drugs such as oxcarbazepine, gabapentin, and baclofen. And if the pain is controlled, then we continue the therapy. But if the patient experiences some side effects, or if the pain is not relieved, then we move on to surgical options. Now we look at the peripheral and ganglionic procedures. the most important procedure is the injection of 90% alcohol. In this procedure, the affected peripheral branch, which is the ophthalmic, mandibular, or maxillary branch, when it is affected, then the alcohol, 90% alcohol is injected in it, which causes chemical neurolysis, which basically means the destruction of pain fibers, and there is temporary relief, but the side effect is that it can cause sensory loss. There is one more option which includes peripheral neurectomy. In this peripheral neurectomy, when there is a damage to supraorbital, infraorbital, or mental nerve, then it is surgically sectioned to stop the pain transmission. It is a simple procedure, but it has its disadvantages as the nerve can regenerate and the pain may reoccur. Now the most important topic, which is the MVD, microvascular decompression. It is used when there is a vascular compression. So basically what we do is we make a circular incision behind 2 to 3 centimeter behind the ear near the mastoid process, and here we perform the posterior fossa craniotomy, and we identify the compressing artery, which is the superior cerebellar artery, and we then separate the artery from the trigeminal nerve and insert a Teflon pad which stops the pain transmission. Now this is very useful as it preserves the nerve. It is a long-term effect and it is used in younger and fitter patients. There are also some ablative procedures. If the patient is unfit for MVD, then we may use radio frequency rhizotomy, gamma knife radiosurgery, glycerol injection, or balloon compression. These damage the pain fibers to stop the transmission. Now in severe resistant cases or refractory cases, what we do is medullary tractotomy, which is an advanced surgical procedure. In this procedure, the spinal tract of the trigeminal nerve is located, and which lies superficially in the lateral medulla, and it carries the pain and temperature sensations. So we surgically section out the spinal tract of the lateral medulla, and we stop the central pain pathway. Now there are many risks to this procedure. It may cause brainstem complications because it involves the brainstem surgery. So as we saw that the treatment ranges from conservative medical management to complex neurosurgical procedures, and this all depends on the severity and the patient condition. Thank you. Now I pass over the mic to Om.
Good morning everyone, my name is Om Kaltekar and my roll number is 47. Today I represent the post-operative care of trigeminal neuralgia. Post-operative care of trigeminal neuralgia is important to recovery and prevent the complication. The first is immediate care. Immediate care is 24 to 48 hours after the surgery. Observe the vital sign and neurological status, and check the facial sensation and corneal reflex, and keep the head at 30 degrees to maintain the intracranial pressure and provide the adequate pain relief. The second is wound care. Where the surgical site, keep it dry and clean. Watch for redness, if any redness, swelling and discharge or CSF leak. After 7 to 10 days, remove the suture. Then next is eye care. If corneal reflex is reduced, we use to artificial tear to prevent the corneal to prevent the corneal ulceration. The fourth is complication. If any complication if any complication are there, like CSF leak and facial numbness, facial weakness, and hearing loss. Fifth is avoid the heavy activity and strenuous activity about the 4 to 6 weeks, and light activity or walking are encouraged to there. Thank you.